Manipulation, medication, or exercise for neck pain. Comparative effectiveness is a focus of many research trials. Comparisons are not only for the success of the treatment in relieving a patient's complaint, but also used often as a measure of the sustainability of those results over time. A recent study compares three commonly utilized treatment approaches for neck pain during the acute and subacute periods, and then measures the comparative effects at 3, 6, and 12 months. The title of this publication is Spinal Manipulation, Medication, or Home Exercise with Advice for Acute and Subacute Neck Pain, a Randomized Trial, by Bronford et al., published in 2012 in the Annals of Internal Medicine. It's always important to pay attention to the types of patients in a study. Here the patients had acute and subacute neck pain. This is important because this designation demonstrates a deficit in the current literature. As usual, prior to designing a study, researchers review the current literature to see what has been studied up to that point in time, the design of those studies, their strengths and weaknesses, and of course, their results. When the researchers performed the literature search exclusively for acute and subacute neck pain, the results were surprising. There were only 3 randomized trials published from 1960 to 2011 that evaluated spinal manipulative therapy for acute or subacute neck pain. One by Hovig et al. Evaluated the treatment response of patients with neck pain of less than 12 weeks, who were randomized into one of 2 groups. One group was assigned to 12 weeks of manual therapy, primarily mobilization, compared to a group managed with usual medical care, consisting of advice, medication, and exercise. The manual therapy group had better results for pain and disability at 8 weeks compared to the medical group, less so at 12 weeks. In another study by Poole et al., researchers compared 6 weeks of manual therapy to 6 weeks of behavioral graded activity. At 3 months, the behavioral therapy group did slightly better than the manual therapy group, but similar magnitudes of change in improvement. In the third study by Cleland et al., a thrust type of manipulation was compared to a non-thrust type. The researchers found that the group assigned to the thrust type of manipulation had better results compared to the non-thrust approach. Now the current study. Let's look at who the patients were in this study. Inclusion criteria were age 18 to 65, primary symptom of mechanical nonspecific neck pain, current neck pain of 2 to 12 weeks duration, and a neck pain score of 3 or greater on a scale of 0 to 10. Participants were asked to refrain from other treatment for neck pain separate from non-study healthcare providers during the 12-week intervention. Now the exclusion criteria. These are pretty standard, including cervical spine instability and fracture, infection, neurologic events, cardiac disease, thromboembolic disorders, DISH, inflammatory and destructive tissue changes in the cervical spine. Also included were disabling health problems, substance abuse, pregnancy, or breastfeeding. Patients were also excluded if they had received any of the study treatments in the past 3 months. Patients were then randomized into 3 groups: manipulation, medication, or home exercise. Let's look at the specifics for each group with regards to protocol and management frequency. For the manipulation group, visits lasted 15 to 20 minutes and included a brief history and examination of the cervical and thoracic spine. Manipulation was comprised of diversified techniques, including high-velocity, low-amplitude spinal adjustments and mobilization. For the medication group, visits lasted 15 to 20 minutes and included a brief history and examination. Advice was given to stay active or modify activity. The first line of therapy was NSAIDs, acetaminophen, or both. Participants who did not respond or could not tolerate first-line therapy received narcotic medications. Muscle relaxants were also used. The choice of medications and number of visits was made by the physician on the basis of the participant's history and response to treatment. For the home exercise group, home exercise with advice was provided in 2 one-hour sessions, 1 to 2 weeks apart, at a university-affiliated outpatient clinic. The primary focus was simple self-mobilization exercise of the neck and shoulder joints. The protocol for the exercise group was individualized to each patient's abilities, tolerance, and activities of daily living. 5 to 10 repetitions of each exercise were performed up to 6 to 8 times per day. Some additional aspects were that the patients were provided a booklet and laminated cards of prescribed exercises. Patients were also given information about the basic anatomy of the cervical spine and advice, which included postural instructions and practical demonstrations of lifting, pushing, and pulling and other daily activities. Specifically, each exercise was held for 2 to 3 seconds with instruction to inhale, exhale, and relax. This was performed 5 to 10 times. At each session, the following was performed in sequence: head retraction with extension, head retraction with side bending, head retraction with rotation, and head retraction with flexion, followed by scapular retraction. The primary outcome measure was a self-reported 11-point numerical pain scale. Secondary outcome measures included the Neck Disability Index, the Short Form 36 Health Survey, global improvement, medication use, satisfaction with care, and cervical spine motion. With a total of 272 participants, there were about 90 patients in each of these 3 groups. The sample size of this study allowed for detecting a change of 0.8 points mean group difference. The researchers used a 1.8 point difference in the pain scale as their standard deviation. Now the results. Generally speaking, spinal manipulative therapy and home exercise were equally effective for this group of participants at all points of measurement, including at 1 year. Spinal manipulative therapy was significantly better than medication, especially after the treatment period, measured at 6 and 12-month follow-up. Let's look at the specific numbers. First, let's look at the change on the 11-point scale over time compared by group. In the top row, I've listed the mean pain scores at the beginning of the study. We see that they're similar. Look at the changes in each group at 12, 26, and 52 weeks. This is not the pain rating, but the change in the pain rating for each group for each time period. If you do the simple math of subtraction, you can see that on an 11-point scale with scores starting at around 5, the change was good, but not curative for most, and also was similar among the 3 groups. There is a problem with the numerical rating scale. Generally, a pain rating of 1 to 4 on the NRS is considered mild, 5 to 6 moderate, and 7 to 10 severe. The relationship, though, is not constant, so that a 50% reduction from a 10 to a 5 is more significant and noticeable to the patient than a 4 to a 2, even though each is a reduction of 50%. In other words, a pain rating at 4 is not necessarily perceived as twice as bad as a 2, or a reduction from 4 to 2 is not necessarily perceived as a 50% improvement. The milder the pain, the less discrete the change. The researchers understanding this looked at the patients another way. They analyzed each group expressed as 50%, 75%, and 100% pain reduction at the end of treatment and at follow-up. Here are the results graphically. This is at 3 months, and we're looking at the reduction in pain by 50%, 75%, and 100%. You can see that medication wedged in the middle always has a lower proportion of patients reporting success, but the comparisons between spinal manipulative therapy and home exercise are close. The same holds true for 6 months. But at 1 year, it appears that those that reported 50% reduction was proportionately similar among the 3 groups. Interestingly, you can see that for the 100% reduction, home exercise actually edges out spinal manipulative therapy. So although we're looking at reported proportions of patients with pain reduction, what we don't know and is not entirely evident from looking at the tables is the statistical measure of the significance of the difference between groups when compared to each other. Let's do that for a couple of groups. Here's an example of the difference between SMT and medication groups who had a 100% decrease in pain at 12, 26, and 52 weeks. Here we can see the bubbles representing the point estimates or average, and we see lines running through them. The lines indicate the difference as a range. They're called confidence intervals and represent the entire range, not just the average difference. Why is that important? When you look at the range, it shows you whether in some cases some of the difference in groups was not significantly different. This is demonstrated on this modified forest plot by the line crossing the 0, indicating no actual difference. When the confidence interval range crosses below that zero line, it questions whether there is a true difference between groups, at least for all patients. Now, let's compare the differences between the home exercise advice group and medication for 100% improvement. I'm going to switch back to the comparison between SMT and medication, and then back to the home exercise and medication group comparison so you can visually see any differences. Notice that the top two indicators for 12 and 26 remain similar, but what changes is at the 52-week comparison showing a significance. Basically double the size difference in favor of exercise over medication compared to SMT advantage over medication. Now, let's use the same modified forest plot graphical representation to take another look at the 50%, 75%, and 100% improvements, but look at them as mean differences between the SMT and medication group at 12 weeks. Notice first that the line representing the range does not cross below zero. Secondly, SMT seems to have a larger effect for the group reporting 75% improvement compared to those in the medication group. But look at the same comparison at 12 weeks between SMT and home exercise. Notice here that all the range lines cross below the zero line, indicating that statistically there is likely no real difference between the two groups, especially for those with a report of 100% improvement, where the point estimate is very close to zero. Regarding the secondary outcome measures for the SF-36, Neck Disability Index, and global ratings, the findings mirror these findings related to pain reduction. Spinal manipulative therapy did appear to have a higher satisfaction rating than the other two therapies. So it's time to summarize the results of this study, starting with the strengths. There is absolutely an adequate size to conduct this study with a total of 272 participants. The groups were randomized into equally sized groups. Baseline characteristics that were variable were statistically addressed. The primary outcome of pain reduction was measured in two ways, the numerical rating scale and also the percent reduction. These were looked at both as percentages of patients who responded to each therapy and also the differences between these groups measured at a number of points in time. Follow-up continued after the treatment period for 1 year. It's important to note when reading a study how the researchers describe their own strengths and weaknesses and how they articulate their conclusions. It is clear that these researchers demonstrated integrity in the self-assessment of their work and the reporting of the results. Now some potential weaknesses. First, there was no control group. To the researchers' defense, it is difficult and perhaps ethically challenging to not treat a group of patients with pain. The only option would be sham treatment, which is difficult to conduct using manipulation. Changes are hard to measure with baseline scores that are in the mild pain range. Because patients were allowed to seek treatment after the treatment phase of the study, there is no way to detect the effect of other therapies for about 18% of patients who in fact did get treated by others. With regard to the effect of exercise on improvement, compliance to exercise over time is difficult to determine. Is it the short-term effects that are long-lasting versus the need for continued or maintenance performance? The researchers indicate in their summary that the evidence suggests that about half of patients with nonspecific neck pain will still have neck pain at a 1-year follow-up. The question is, did this study beat that natural history? Well, that depends on the definition for no pain. In this study, for patients in the SMT and home exercise groups, about half of them obtained 75% relief. However, at 1-year follow-up, only 27% of the SMT group and 37% of the exercise group reported being pain-free. Said another way, 73% of the SMT group and 63% of the home exercise group still had some pain at 1-year follow-up, and it was even worse for the medication group, with 83% not totally relieved of pain. So, although the 3- and 6-month results are encouraging, the 1-year results are disappointing for all the therapies. This raises some questions about, certainly at the very least, the chronic nature of spinal pain, also seen with low back pain. We need to do better. So in summary, the researchers should be congratulated on a well-designed and executed study. It's an important first step in determining the value of standard chiropractic management of acute and subacute mechanical neck pain.